the EMR, I love our EMR, but I really love our colonoscopes. And our colonoscopes, I treat them very well because they help us a lot in colon cancer surveillance, a large part of what we do. And what I'm going to try to do today is to review some screening recommendations. The talk is really on surveillance, it's not on screening. So when we look at screening, it's really to try to find a disease, and if we don't find it, when we do it again, it's screening. But when we find a disease or a surrogate marker, like polyps in this instance, it becomes surveillance, and that's what we're going to talk a little more. I'm going to review a bit some polyps, the neoplastic and non-neoplastic polyps. And then when we talk about surveillance, we're going to talk about the different risk factors, the low-risk patients, high-risk patients, and what has been newer in the newer guidelines is really what do we do with patients who have serrated polyps. We're going to talk a bit about quality indicators for colonoscopy. And briefly, I'm going to touch on emerging technologies, but mostly the stool DNA, since this is something that you are seeing probably in your practices now. So colon cancer is very common. It's the third most common incident cancer, and it is, however, the second in terms of cancer mortality, just behind lung cancer. And this is in both men and women. And the lifetime incidence of developing colon cancer for any individual is about 5%. The good news is that the incidence and mortality of colon cancer is decreasing. And when models are done to look at why is it decreasing, about 53% is said to be because of the screening that we have been doing. Between 1987 and 2010, close to 500,000 cases of colon cancer have been prevented. And there are some other reasons why mortality has improved, and part of that is also because we've had some improved therapy. Oh, this slide, the goal of screening, this slide really flipped up, but the goal of screening is that we're trying to decrease mortality by decreasing the incidence of advanced disease. And there's two ways we can do that. One is to detect the cancers at an earlier stage. And what this is trying to show here is that when we obviously find cancers that is only in the bowel wall, the survival is pretty good at 90%. When there are regional lymph nodes involved, the survival decreases to 68%. So if you can find them early on, you will help mortality. But more importantly is to try to do early detection where we can actually find polyps and prevent cancer altogether. There are multiple societies that have put out guidelines over the years. The first was the American Cancer Society in the 1980s. And since then, there has been multiple revisions to the guidelines. And then there's the U.S. Preventive Services Task Force. The American College of Radiology have put out guidelines. And this is the U.S. Multi-Society Task Force, which is a conglomerate of the 3 GI societies that have come out with some guidelines. And then the ACG, the American College, has their own, the National Cooperative Cancer Network, and there are a variety of others. But what I'm going to talk about today, in terms of the screening, is the 2008 screening guidelines, which are from this Multi-Society Task Force, but have also been done in conjunction with the American Cancer Society and the American College of Radiology. And then for surveillance, it really is the U.S. Multi-Society Task Force of 2012, which we're going to focus more on. So the screening guidelines, what is a large part of it is that the primary goal is prevention, not early detection. And it is best to have, or at least they favor, a test that you may do once and not repeat so often. But it has to be a fairly sensitive test. You start at age 50, and it's said that you should stop screening when life expectancy is less than 10 years. The tests that are available, and this is the first time in 2008 where there's 2 tests that were involved in the guidelines. The 2 tests that were added were the Stool Dna, is actually part of the guidelines, and the CT colonography. So the stool-based tests that we've known for a long time have been the guaiac fecal occult blood test, as well as the immune fecal occult blood test. And in terms of structural tests, we've had the double contrast barium enema for a long time. Those are included in the guidelines. This is the CT colonography. We'll talk a little bit at the end a bit about CT colonography, but even though it's included in the guidelines, it's not something that is done very, very frequently for several reasons that we'll review, and that's why I'm not going to dwell on that. And endoscopic, the flexible sigmoidoscopy is still included in, but most of what we do endoscopically is the colonoscopy. So the guidelines of 2008 recommend for early detection and prevention that we do a colonoscopy every 10 years. And that, even though it really is a screening, we'll talk quite a bit more about the 10-year issue when we talk about surveillance after. The CT colonography, if one was to use CT colonography, it's recommended every 5 years. And if there were polyps on the CT colonography of 6 millimeters or more, a colonoscopy is recommended. Flexible sigmoidoscopy would be every 5 years, and a double contrast barium enema every 5 years. But I would challenge a lot of people to find a radiologist nowadays that really does a lot of screening barium enemas. The technology has evolved so much with CT colonography that very few radiologists are actually doing barium enemas anymore. So even though it's in the guidelines, it's not one that it's almost obsolete. And in terms of fecal occult blood test, the guaiac and the immune fecal occult blood tests are recommended every year. The problem with the stool DNA is that it's not known when you should repeat it, if you were going to use that as an early detection. It's not known whether you should do it every year, every 2 years, or every 5 years. The other guidelines from the U.S. Preventive Services Task Force don't include stool DNA, and they don't include CT colonography. So the only modalities is you either do a FOBT every year, or you do a combination of sigmoidoscopy every 5 years with an FOBT every 3 years, or you do colonoscopy every 10 years. So when we do screening, we're looking for polyps. And when we find polyps, they can be either non-neoplastic or they can be neoplastic. In the non-neoplastic, the most common one that we've known over the years has been the hyperplastic polyp. I put it in brackets because the hyperplastic polyp is now felt to be more a segment or should be classified under the serrated polyps, which are in large part neoplastic, and we'll talk about that in a little more detail. Other non-neoplastic polyps include mucosal polyps, inflammatory polyps. Sometimes we'll find some submucosal lesions, maybe a lipoma, and some Adenomatous polyps. But the important ones for us in terms of screening and surveillance is the serrated polyps and the Adenomatous polyps. The serrated polyps include the hyperplastic polyp. So most of the hyperplastic polyps that we find, and we found over the years, have been these little, tiny little polyps, 5 millimeters or less. They're usually in the rectosigmoid, and they do not increase the risk of colon cancer. However, there's some of these hyperplastic polyps that can be large, greater than 10 millimeters, or if they're found more in the proximal colon, it's felt that these might be precursor polyps to the sessile serrated adenoma and may progress to cancer. And we'll talk about this sessile serrated adenoma on the next slide. When people have larger hyperplastic polyps, there's an increased risk at the time of that colonoscopy, meaning the synchronous, meaning you find it at the same colonoscopy. So people who have these more proximal hyperplastic polyps or larger hyperplastic polyps are at increased risk of having advanced adenomas. Those are adenomas that give you an increased risk of colon cancer. And you're more likely to find multiple adenomas in these patients. And there's also an increased risk of metachronous adenomas. Metachronous means, as opposed to synchronous. Synchronous is when you're doing that initial colonoscopy, at the same time you find other polyps. Metachronous is on a subsequent colonoscopy, which is important for surveillance. So these patients are at increased risk of developing adenomas in the future. There is a syndrome called the serrated polyposis syndrome, which is not very common. But it used to be called the hyperplastic polyp syndrome, which are patients who have multiple, so greater than 20 hyperplastic polyps, or they have more than 5 with several that are large, or they have one or more with a first-degree relative with this syndrome. These patients, even though they're hyperplastic polyps, are at high risk of developing cancer. And it is recommended in these patients that they have a colonoscopy every year. So these polyps, the serrated polyps, the sessile serrated adenoma and the traditional serrated adenoma, are polyps that are being increasingly recognized. And they're actually one of the main reasons that the guidelines were updated from 2008 to 2012. Is because in the old guidelines, there was no mention of serrated polyps. And as we are getting better with our bowel preps, we have better colonoscopes, we have better training, everything, we are finding more and more of these polyps that we were probably missing in the old days. And the sessile serrated polyp is typically in the proximal colon, and it usually lacks dysplasia, but there can be foci of dysplasia and foci of cancer within them. And the traditional serrated adenoma, it's typically in the rectosigmoid, and it does have some mild dysplasia. And these polyps they do have a significant malignant potential and should really be dealt with like adenomas. One of the difficulties in finding them is that when we do a colonoscopy, there can be mucus overlying those polyps. They're flat, their borders are indistinct, and with that mucus on top, often stool will stick to it, and unless you have a very good colonic preparation, you may not see them, and patients can develop, and it's thought that these are a high likelihood of developing interval cancers, and we'll talk a little more about interval cancers after. Adenomatous polyps we've known for a long time. They're the most common polyps of all. About 2/3 of all polyps are adenomatous. About 95% of cancers, colon cancers, are felt to arise from adenomas. But most adenomas don't cause cancer. The problem is we don't know which one is going to cause cancer. The prevalence of finding polyps at your initial colonoscopy is about 30%. So patients often ask, why do I need a colonoscopy at age 50? Well, there's a high likelihood that we will find, being 30% or so, of finding adenomas. And if you have an adenoma on that initial colonoscopy, there's about a 30 to 50% chance that you will have another adenoma at that same colonoscopy. So you'll have 2 adenomas or maybe 3. The risk of advanced adenoma is about 4% at baseline. But if you go up to over age 65, it's up to 8%. The advanced adenomas are the adenomas that are big, so greater than a centimeter, if they have evidence of high-grade dysplasia, or if they have any villus features. And those 3 features for advanced adenomas increases the chance of having cancer within that polyp. The risk of developing polyps in the future includes the polyp size, but the other factors is not necessarily the villus or the high-grade dysplasia. The risk of developing polyps in the future, which is important for surveillance, is the number of polyps that are found is a good determinant of developing polyps in the future. And patients who have had multiple polyps over multiple colonoscopies. So the lifetime number of polyps is important in determining the risk of developing future adenomas. So the guidelines that I'm going to review are from 2012. And as I said, they were from the Multi-Society Task Force, but they were also endorsed by the American Cancer Society and by the American College of Radiology. They point out the importance of stratifying patients. And what we usually do is we stratify patients into low-risk adenoma patients and high-risk adenoma patients. And the low-risk adenoma patients are the ones that have 1 or 2 small adenomas. And small is defined as 6 to 9 millimeters, anything less than a centimeter. The high-risk adenoma patients have polyps that either have villus histology, high-grade dysplasia, or greater than a centimeter, so the so-called advanced adenoma, or if they have more than 3 small adenomas. So we're going to go through some different scenarios of the findings of the initial colonoscopy, the baseline colonoscopy. So if your patient comes in, we're doing screening, and we find that they have no polyps. Everybody nowadays are like, I'm told I don't need a colonoscopy for 10 years. And the guidelines say that, you can go 10 years. In fact, CMS is telling us that we have to tell patients that they have to come back in 10 years. But the quality of the evidence for this is moderate. And moderate in their definition is that if there was a new trial to come out in the next year or two, it's likely that these guidelines would change. So, it's good evidence, but it's not high quality evidence. If you look at the studies, there's several studies that have looked at polyp surveillance. And these are the different studies, the number of patients, and if you look at the 5-year, how many at 5 years have advanced adenomas? Not just any polyp, but advanced adenomas that have the higher risk. You can see that overall about it's hidden over here on the 1.3 to 3.4% will have advanced adenomas at 5 years. If you look, there has been some concern for giving a 10-year interval. There's been 3 population studies that were done in Canada because they have a large database. It's one single payer per province. Being from Canada, I know that it's very easy to get the data. They have, it's fairly easy to do population-based study. And what they've done is that they've found that of all the cancers that were diagnosed, 9% are interval cancers. And interval cancers are cancers that are found during the surveillance. So before your next colonoscopy would have been recommended. And the majority of these cancers were found 1 to 5 years after they had the colonoscopy. So if you go 10 years, it might be a bit of a problem. If you do at baseline you find just a small distal hyperplastic polyps, the evidence or the recommendation is 10 years, and the quality of the evidence is moderate. Most of the small polyps, most of the hyperplastic polyps are small. And again, this would be similar to the last slide, where if you have a negative colonoscopy, you deal with it the same way. If you have 1 to 2 small adenomas, it's recommended that you go 5 to 10 years for colonoscopy. But then the issue is, do you do 5? Do you do 6? Do you do 8? It's kind of a wide range for recommendation. If you look at the studies, similar studies that we looked at earlier, and you look at the 5-year advanced adenoma in patients who had at baseline 1 to 2 adenomas, the chance of finding advanced adenoma at 5 years is anywhere from 2.4 to 5.3%. So if you think that the baseline advanced adenoma is 4 to 10%, and at 5 years you have 5%, then why would you go 10 years for subsequent colonoscopy? So really, the best is to do a 5-year interval when you have a few small adenomas at baseline. In terms of multiplicity of adenomas, this is an important determinant of having subsequent adenomas. There's a study of the National Cancer Institute where they've pooled a lot of these studies looking at surveillance and the recurrence of polyps. And they find that if you look at the number of polyps, as you go from 1 polyp to more than 5 polyps, the chance of finding advanced adenoma increases significantly. So that's why the recommendation when you have 3 to 10 polyps is not 5 years, but you should go to 3 years. I mentioned earlier that in the US task force, the risk stratification was in low and high risk adenomas. But the British have done 3 classifications. So they have the same low risk adenoma patient. They have an intermediate risk adenoma patient where 3 to 4 adenomas are present. And this is what they will do 3 years, just like the US does 3 years here. But they've classified a different high risk adenoma patient. And this higher risk is 5 or more adenomas of any size, or 3 adenomas where at least one is greater than 10 millimeter. And the reason they did this is because if you do a colonoscopy and you find more than 5 adenomas, even if they're small, there's a high likelihood that you may have missed other adenomas. So the recommendation here is to do a colonoscopy at 1 year, not at 3 years. If you, in the US recommendations, they say you do 1 year colonoscopy if you have 10 or more adenomas. But as I say in the British, they would go at 5 adenomas. And if you do find a patient who has multiple adenomas like that, in addition to colonoscopy, you really should consider hereditary syndromes and genetic testing. If you have an advanced adenoma at the baseline colonoscopy, the recommendation is 3 years. And in terms of the size of the polyp, the recommendation, the data quality is very good. In terms of histology, it's not quite as good. And we see it clinically is that sometimes we'll have a small polyp, maybe a 6, 8 millimeter polyp, but it ends up having a bit of villus tissue in it. And we're like, So if they have villus, according to the guidelines, you have to do 3 years, but it's a very small polyp. And so we don't know in a lot of these trials whether we can separate the villus histology from the size of the polyp. And so right now, as it is, if there is any villus tissue, no matter the size, you should repeat a colonoscopy at 3 years. Now, the serrated polyps are the ones that were not included in the prior guidelines. The risk of serrated polyp appears to be related to their size, to the histology. So sessile serrated polyps are higher risk than hyperplastic polyps. If they have dysplasia, they're higher risk than without dysplasia. And the location is important. As I mentioned earlier, proximal serrated polyps are at higher risk than distal. So anything proximal to the sigmoid colon. So the recommendations are that if you have sessile serrated adenomas that are greater than 1 centimeter, or if there's any dysplasia, or if the traditional serrated adenomas, we should do a 3 year. And if you have one that is small and has no dysplasia, then you could go 5 years. But when there's serrated polyps like this, you shouldn't go 10 years. So after you've done your first surveillance, the issue also arises as to when we should do the second surveillance. And the guidelines suggest that if you have a low-risk adenoma at baseline, you do your first colonoscopy, so there's the first surveillance colonoscopy, and there's nothing. They say that you can go 10 years. And the problem is that the studies that looked at this, on which these recommendations are based, where there's a low-risk adenoma at baseline, negative first colonoscopy, the risk of advanced adenomas at 3 to 5 years is 3 to 5%, which is pretty high at 5 years. Yet they recommend that you can go up to 10 years, which is a bit of a stretch, in my opinion. So what I do in these patients, if they've had polyps before, they have a negative, I repeat at 5 years. The low-risk adenoma patient has a surveillance and has a low risk, you continue at 5 years. If it's a low-risk patient, and the subsequent one, they have a high-risk advanced adenoma, you go to 3 years. And the same if you have a high-risk adenoma at your baseline colonoscopy, and then you do a surveillance colonoscopy and it's negative, then you should go 5 years. If it's baseline high and you have a low-risk adenoma, you should go to 5 years. And if it's high risk and high risk, you should continue at 3 years. The importance in these recommendations is that colonoscopy has to be of high quality. And this is very important when we talk about these interval cancers. So these are some of the quality indicators that we follow to see how good colonoscopy is. Nowadays, it's recommended that gastroenterologists or whoever, or endoscopists, have a scorecard to look at how much adenoma, what is their adenoma detection rate. And the average risk of adenoma should be about 30%, but it can be anywhere from 22 to 58%. And now with the newer scopes, the high definition scopes, it can be as high as 40% adenoma detection rate. There's a cecal intubation rate should be 95% or more. And that is a problem in some of those interval cancers that some of the physicians that were doing colonoscopy may not have been very good at having good cecal intubation rates, so you can miss more cecal cancers and right-sided cancers. Some are suggesting that adherence to surveillance guidelines should be part of the quality indicators. And certainly bowel preparation should be included in the report of colonoscopy. When a bowel preparation is said to be inadequate, when you repeat a colonoscopy later within a year, you can find 35% adenomas and 36% advanced adenomas. So the recommendation is that if you have an inadequate one, you repeat a colonoscopy within a year. But if the bowel preparation is fair and felt to be somewhat adequate, which is a definite, what the endoscopist should be comfortable that they may not have missed lesions 5 millimeters or more, then you can go to 5 years. But most of us will probably do 3 years of bowel prep is not very good. The colonoscopy is not it's the gold standard, but it's not perfect. This is a study here looking at back-to-back colonoscopy in 183 patients that was done at Indiana University. So what they did is that patients came in that morning, had a colonoscopy by Dr. A, and then right after they were done, they had a colonoscopy by Dr. B. And then they looked at how many polyps Dr. B found that Dr. A missed. And you can find that 27% miss rate for polyps that are very, very small. The 6 to 9 millimeter, there's a 13% miss rate. And in greater than a centimeter, there's a 6% miss rate. So this is important when we try to tell patients, you're going to do that 10-year colonoscopy, or are you going to want to go maybe at 5 years? The same thing in the CT colonography trials that were done where we look at segmental unblinding. So the way these trials were done, and I used to do some of these trials, some of the initial ones when I was at Wake Forest, is that patients would go for a CT colonography that morning, and then right after they would get a colonoscopy. And so we would go all the way to the cecum, and then once I would clear the ascending colon, and we would say, okay, there's no polyp. Then we would open the envelope from the CT colonography, what they saw. And if they saw a polyp that I didn't see, I'd go back into the ascending colon to see. Well, when these studies are done, you can see that there's a miss rate for polyps greater than a centimeter of 12 to 17%, which is not insignificant. So interval cancers majority are felt to be directly related to the quality of the exam. Some is related to the incomplete resection of polyps. When you look at these interval cancers, up to 27% or so of these cancers arise in a location where the polyp was on the last colonoscopy. So the thought is that there may be incomplete resection. And there's also thought that these cancers may be biologically different than other colon cancers. They're more proximal, they have more microsatellite instability, and they also have this CIMP positive gene factor, which is mostly seen in sessile serrated adenomas. So these flat polyps that have mucus on them that are difficult to see may be a large component of these interval cancers. Now, stool DNA, I really wasn't going to include it initially because it's really not part of surveillance. But since it's a newer technology that just came out and was just approved, and you're probably seeing this in your office, I wanted to touch base quickly on this. It was approved in 2014. There was an earlier form of this stool DNA that was withdrawn from the market. And the stool DNA, what it's trying to do is to look for molecular assay for DNA mutations and methylation. So that's how they came out with their first test, and it wasn't very, very good. So what they did is that they added an immunochemical FOBT. So now that there's a combination of FOBT and DNA testing is the test that we have today. It's called Cologuard, and it detects 92% of colon cancer. But it only detects 42% of adenomas. So if we're looking at early detection, it's okay. But if you're looking at prevention to find polyps, it's not a good test for prevention. It is actually contraindicated for surveillance. So people who have had a history of adenomas or a history of cancer should not get this test. People who have a family history of colon cancer should not get this test. Anybody with symptoms, diarrhea, hemorrhoids, fissures, should not get this test because there's an immune FOBT in it. There's a study in 2014 looked at immune fecal occult blood, stool DNA, and colonoscopy. And if you look at how many tests are needed to find one colon cancer, you need to do 208 fecal occult blood tests, 166 stool DNA, and only 154 colonoscopy. And the beauty about colonoscopy is that then you can just, you have an interval and you know where you stand and you don't have to repeat testing over the years. And as I said earlier, for stool DNA, if you use it as screening, we don't know when you should be repeating it. There's absolutely no guidelines. And if you read the package insert for stool DNA, this is what it says. Patients with a negative Cologuard test should be advised to continue participating in colon cancer screening program with another screening method. So if you do Cologuard and it's positive, well, you have to do colonoscopy because they could have cancer. And if it's negative, according to their insert, you should still do another screening method, which really should be colonoscopy. So I think that this test is good for patients who are really fearful of colonoscopy. And then if you find something, you can at least try to convince them to undergo colonoscopy. CT colonography is a CT-based screening method. I'm not going to talk much about it because two reasons. One is that it requires radiation to do the test. And two, most importantly, it's not covered by insurance. So you can't really use it. So in summary, what I would recommend is that colonoscopy be repeated at 10 years. This is what I do in my practice. 10 years if you've had 2 negative colonoscopies in a row. Or sometimes we see patients that are age 40 to 50, or let's say they're 45, they come in and they get a colonoscopy for whatever reason, slight rectal bleeding. Those patients, I'll just do 10 years, not do it at age 50 as the recommendations would, the guidelines. 5 years, so if patient has a negative colonoscopy, I repeat them at 5 years for the first time. And I would continue 5 years if there is a first-degree relative less than age 60. If patients have 1 to 2 small adenomas, should be 5 years, or if they have sessile serrated adenoma without dysplasia. 3-year colonoscopy should be those that have 3 to 5 adenomas, high-risk adenomas, so advanced adenomas, and the sessile serrated polyps greater than 1 centimeter, or with dysplasia, or the traditional serrated adenomas. I would do 1-year colonoscopy, contrary to the guidelines. I would do 1-year colonoscopy if they have more than 5 adenomas because of the chance of missing polyps in that initial colonoscopy. Or if they have more than 3 adenomas with 1 that is large, or if there's a malignant polyp, I would do a year. And there are some that will need colonoscopies within the year. We talked about the inadequate bowel prep, but there's also these large flat adenomas that we sometimes will resect them and we're not confident that we've gotten all the borders. These patients should be repeated within a year to be sure that there's no recurrent or that you've got the whole polyp. And I would, that's all I have for today, and I thank you for your attention. Yes?
Over the years, I've noticed that I get so many different types of recommendations from different reports, from the same group, about when to have the next colonoscopy. So I started doing a fecal immune test after 5 years, just because I'm afraid they missed something. Okay? Do you pick up those low-risk adenomas? Do they bleed? Is there anything you find on a fecal immune test that would highlight any of those lower risks?
The low-risk ones are not detected. And so if you find them at the time of colonoscopy, it's just by chance. But to your point of doing it at 5 years, if the recommendation, if somebody says you're going to do a colonoscopy at 10 years, I think doing a fecal occult blood test 5 years and after is reasonable. Doing it in the first 5 years I don't think is necessary, and actually the guidelines say you should not do it. But after 5 years, I think it's reasonable. Yes?
I want to add a tip for how
Sure.
That's a minimum quality check that the gastroenterologist should provide to the referring physician. And if your gastroenterologist isn't showing you, giving you a picture, then you can't have confidence that they really got to the sequence and got an effective result. I always insist on that from your specialists. Show me a picture for every patient.
I think it's good that we take pictures. I'm not sure it's necessary to send it to the referring doctor. Just like, when my radiologist tells me that there's a spot somewhere, I take it that they're well trained and that what they see is what they got. I don't need to see the image. That's my view. But if that's, I do think though taking a picture is very good for quality indication. And in fact, that's what we do in our practice. These pictures are reviewed, and that's how we know the rate of cecal intubation between physicians.
I have a question.
Yes.
Talking about trusting the radiologist, you are right, but there are many times left and right are not done properly, and we have documented over 20 cases this year with a radiologist in town. So that is another thing that one need to confirm that the patient was sent for right, left, whatever, and that is done properly, reported properly. Even fractures have been missed, which I think is pretty normal. Number two, where is the magic number coming from that you start colonoscopy at 50? Because today, last 2 weeks, we had 2 patients, 38 and 45, with colon cancer. And there were no family history, but both were overweight, to put it pleasantly plump, rather than fat, overweight, or otherwise. So what is the correlation there as well?
Well, the age 50 is because of the incidence of polyps and of cancer increases really after age 50. Now, it doesn't mean there's no cancers earlier. And then that's where you look at family history. And these 2 didn't have family history, but there are some sporadic genetic mutations that can occur. And it's a cost-effective issue. So if you screen everybody, if you want to find them all, you start screening them at age 25. But we just can't afford that. And so age 50 is kind of the cutoff for population-based, cost-effective screening. Now, your first question was about the radiologist having, yeah, sure, but they can miss a fracture. Anybody can miss anything. I mean, nobody's perfect. But sending me a picture of the bone, I'm probably not going to see the picture, the fracture.
This one, I don't need a polyp that you have taken the picture. It doesn't make any difference. I have to collect and keep it on my computer much more, so I don't need your pictures. On the other hand, what you write, the histology, the report that comes out, that is important.
Right.
Okay? And
I agree.
We have time for one more question.
And
Yes.
how are you following, I'm not a gastroenterologist, how are you following patients that have like a positive Polaris genetic screen? How often are you following it?
A positive Cologuard? Oh, well, it depends. If it's positive, you should probably go every 2 years. In what situation, it also depends on the situation, but usually it's about 2 years.
Well, Ben, thank you very, very much. Let's think about
Thank you.